Thank you very much.
Thank you, Professor Vitull, for inviting me. It's an honor to be here. No words to thank you for giving such good words for my father. He was an awesome, excellent father and a teacher in all respects of life. God bless him. Thank you, sir. Let's start this topic. So, sleep disorders. I'll be touching the subtypes, the causes, and the management. I'd like to share a painting by a Russian painter. It's a world-class painting by Vitull. A phrase for sleep is a good laugh and a long sleep are the best cures in doctor's life. What's the definition? Sleep is a reversible behavior, a state of perceptual disengagement and unresponsiveness to one's environment. We can also define sleep as a period of rest for the body and the mind, during which volition and consciousness are in partial or complete abeyance and body functions are partially suspended. Sleep is important to a number of brain functions, including how nerve cells communicate with each other. Humans normally sleep in a supine position with eyes closed, and unusual phenomena are observed clinically, which could be sleepwalking, which I will be touching later, and sleep talking. The first question comes, is sleep active or a passive process? It used to be thought that it's a passive process. When one sleeps, you really don't know where you are, what happens to your mind, what happens to your body. But with much of the investigations now, we can prove it that sleep is an active process. The reasons, in fact, the brain and the body stay remarkably active while sleeping. And how to prove it? It is supported by PET scan and functional MRIs. You can see the red spots over here. The PET scan and the functional MRI shows that the red areas denote state of higher activity even during the rapid eye movement sleep, which is the REM sleep. And I've depicted a picture of a normal sleep also, but you can see in both the pictures, the red spots are there. So that means that there are definitely a higher amount of brain activity is going on even when you are sleeping. Another question comes, why do we sleep? What is the necessity to sleep? Because if statistically we go, 1/3 of our life is spent in sleep. Different theories have been put forward. I'll be enumerating mainly the 6 theories which are accepted worldwide. The first was, it used to be a protective behavior adaptation, or it's a energy conservation. Some postulate it's a hormone regulation. It's memory consolidation, creativity or brain restoration. Immune function regulation through natural killer cells. And the last is emotional balance and mood. I'll be touching briefly on every topic. Now first, few thought that it's a protective behavior adaptation because it was thought that during 24 hours, the species and the animals need to protect themselves and they slept. But didn't hold true for all of them, because some sleep maybe for an hour and some sleep for maybe 16 or 18 hours. So it doesn't hold true for everybody. The second is energy conservation. It was postulated that in order to survive, body needs rest to conserve energy. But this theory has its own limitations. Few hormones have been associated with the sleep mechanism. The main hormones being melatonin, cortisol, growth hormone, and thyroid. Few more hormones have also come into play. They are acetylcholine, 5-hydroxytryptamine, norepinephrine, gamma-aminobutyric acid, orexin, or serotonin. Now, for hormone regulation during sleep, it's a melatonin which is production starts well before we start sleeping, and the peak is there at the midnight, and after the midnight it starts falling. Cortisol levels are low at the night when we start sleeping, but they peak early in the morning. Normal time is 4 to 5 a.m. in the morning. Thyrotropin also peaks at night. Growth hormone also peaks at night. And the cerebral blood flow peaks during the midnight. The fourth theory which is being discussed is memory consolidation or creativity. Now, whenever we receive some information, it is stored in the brain just like a computer. And the specific formulation is there is an encoding of this, there is storing, there is this followed by imprinting, and afterwards you can recall those things. We call it as memory. You met somebody, you meet in the next day, or maybe in the later life, you can recall the person's name, you can recall the face, or the textbooks, or the material which you guys are reading over here. So encoding, storing, imprinting and recall, that is the fashion in which the brain functions. Sleep plays a housekeeping role. Like we dust our house, we clean our house. Sleep removes the toxins and the metabolic waste, just like immunoglobulins or the proteins like beta amyloid, protein fragments from the interstitium of the brain through the lymphatic system. And how? Because these things, they build up during the awake state and they settle down during the memory. Now I'd like to touch a point over here that beta amyloid, non-clearance, if they're not cleared and get deposited, they pose a big risk factor towards Alzheimer's. The first is immune regulation or immune function regulation. Gets activated during night, especially increased production of natural killer cells. Now what are these natural killer cells? They are WBCs basically, which destroy the infected and the disease cells and thereby preventing the viruses and even the cancer cells from spreading. So they help in restoring the brain and preventing further infections or the malignancy in the body. Last, which carries a lot of weight, is emotional balance and mood. Sleep deprivation leads to excitation of amygdala lying next to hippocampus. If you don't sleep for a night, for 2 days, like we often have in our medical profession, we have duties, night duties and all. So if you don't sleep for 2 days, what happens is that the amygdala gets excited. Amygdala, the main functions of amygdala are emotional responses like happiness, fear, anger and anxiety. Excitation of amygdala leads to phase of irritability, anger and mood fluctuations. Now, it has been postulated because of this continent that amygdala excitation is one of the precursors for substance abuse also. In contrast, prefrontal gyrus, the cortex, exerts suppressant effect on the amygdala. Sleep plays an important role in maintaining the normal homeostasis of the body. Another painting is a world-class painting by The Knight's Dream. It's a Spanish painter. Now what is it? I'll be briefly touching the anatomy, the physiology, and thereby we'll touch the medical part, the diseases associated with the sleep. The anatomy of the sleep is that suprachiasmatic nucleus is the one which we'll be discussing for this part, which is situated in the anterior part of the hypothalamus. It is the central pacemaker of the circadian rhythm. The afferent tract, they start from the eyes, that is the retino-hypothalamic tract, and the efferents go to the pineal gland, which thereby secretes melatonin. Now I've depicted a picture over here where the light is there, the retinal cells, the retinal ganglion cells get excited. The information goes from the retino-hypothalamic tract to the pineal gland, and thereby the cycle gets. It's a sleep-wake cycle which comes up, and you have arousal, then there is rapid eye movement, the timing and consolidations I'll be touching all briefly. The physiology of the sleep is that there's a dark room. In the evening when you go to your room, it stimulates the suprachiasmatic nucleus. There is a release of norepinephrine. This norepinephrine acts on the pineal gland. There is a release of melatonin, which initiates the circadian rhythm. And this further, there's a release of prolactin, ACTH, norepinephrine, and further melatonin is secreted, and the cycle is repeated. Now often a question comes, what starts the circadian rhythm? It is the melatonin, not a dark room, which starts the circadian rhythm. It's deficiency of melatonin. If there, then you don't have a proper sleep. The circadian rhythm will be disturbed. And what starts a sleep cycle, you need a dark room, you need a dark ambience. Regarding the physiology, I'll be briefly touching the two factors. One is factor S, other factor C. They play basically the role in the sleep part. Factor S is a homeostatic factor dependent on number of awake hours prior to the sleeping phase. And during the awake hours, you have accumulation of adenosine. You can see in the first block, the upper part, right from 7 a.m. there's accumulation of adenosine and one keeps awake. If the adenosine gets built up, you remain awake. And the other factor is factor C, which is a circadian factor, which is maintained by the suprachiasmatic nucleus. Adenosine gets dipped in the late evening and the sleep starts. And for circadian law, the biological clock we have, again, in the evening after 8 p.m., adenosine deficiency is there, blood levels get low, and the circadian factor gets in. A sleep-awake cycle in which both the process S and process C I have tried to show over here. The adenosine levels get up to 8 p.m. Alertness is there, and followed by the dip in the adenosine and the night sleep starts. And again followed by, in the morning, you have again awakeness. A brief word for the normal awake sleep cycle. Now, the sleep can be divided into two groups. You must be reading over there. The non-REM sleep and the REM sleep. Non-REM sleep is also called the non-rapid eye movement, and REM is rapid eye movement. Non-REM sleep can be further subdivided into different stages, stage 1, 2, 3 and 4. But currently, from 3 years back, we have only stage 3 because stage 3 and 4 are collectively now known as slow wave sleep, and we have just stage 3 and there is no stage 4. So N1, N2, N3 will be discussing in NRE. Now in the general awake and the sleep pattern, we have an awake pattern, we have an NREM pattern, and we have REM pattern. Different waves have come up. That's how we diagnose for the disease part. There are beta waves, there are alpha waves, there are theta waves, there are spindles, there are delta waves, and followed by again the beta waves. Now, in order to how to know that how these waves are there, there's a phenomenon which we have made it that the bats drink blood. You take the first word, BATS, D on the left hand side, you can see. Bats drink blood. The first is B, there's a awake state, the eyes are open and there are beta waves. It becomes easy to understand the disease and it becomes easy to understand the cycle. Then again, in the awake state, if you have the eyes closed, the alpha wave set in. That's the other part of the bat, A. For non-REM sleep, we have the first is N1, the theta waves. The T stands for theta waves, also called as positive sharp transients or post. N2, they're basically called, they have the sleep spindles or the K complexes, and the only disease associated in the N2 phase is teeth grinding or bruxism, which is very common. Often clinically you have patients with it. For N3, you have D, the delta waves, which are low frequency and high amplitude waves. And sleepwalking, night terrors are observed in this phase. Often bedwetting, if you come and try to have patients clinically, bedwetting is there, and we use imipramine clinically because that's the only drug which decreases the phase N3, and this is abolished. You can absolutely cure the bedwetting part. So N3 stands for D, delta waves, low frequency, high amplitude, sleepwalking, night terrors are there. And the last is REM sleep or rapid eye movement, The B is there because the last word for the blood. Beta waves again set in. It's the dreaming part, dreaming sleep, or the memory processing takes place over here. And if you arouse any person from the sleep and he or she is in the REM phase, they remember the dream. Otherwise, for non-REM, if the person is sleeping, you awake, he will not remember the dreams. Typically, saw through appearances there. Now these appearances are there on a polysomnography, which we do a test to. It's a full night test for 10 to 12 hours. We call the patient in the evening. He has his light dinner and sleeps till morning, and we have the conscious recordings, which we are doing in Ludhiana also. So for REM sleep, I'll repeat again, the beta waves, the dreaming and the memory processing takes place. You remember the dream if you get woken. Sort of appearance is there. Now all your body muscles are paralyzed except extraorbital or the breathing muscles are there. And that's the only reason why you have the rapid eye movement, because of extraorbital muscles. Now often we clinically encounter issue that what is latency. Now a broad definition for latency means how long until. What is sleep latency? It's the time taken to fall asleep. Some take 5 minutes, some take 20 minutes, some take, you keep on tossing the beds, 30 minutes. And what is REM latency? The time taken to get into the REM phase after N1, N2, N3. That time is important. How much time you take to go to the REM phase. Because now the disease, the clinical management will come now. Now in depression, I have taken the depression part basically. We have a number of diseases, but depression being one of the most common being encountered in our society. So what happens to sleep latency, what happens to REM latency, what happens to N3 delta, and what happens to REM density. So in depression, you have increased sleep latency while you fall asleep late. And REM latency, how much time you spend in REM, it is much more decreased. And N3 delta is again decreased, and REM density is much more increased. Now first REM in depression is always increased one. That's why you see on the polysomnography. If we give antidepressants or SSRIs, we suppress the REM sleep. That's the treatment part, how we do it. Now few conditions in which you encounter increased REM latency are restless leg syndrome, which is very common clinically, and older adults. Older adults, the sleep is too less. They have decreased REM. They sleep early. They get up around 11 in the midnight. They can't sleep. Then they sleep maybe around 2 a.m. and then again get up around 4 a.m. So they have very less sleep. And conditions with decreased REM latency are depression and narcolepsy. Now for a normal sleep pattern, there are 4 stages basically. Stage 1, 2, stage 3 and 4 are combined, and another is REM sleep. Now you see over here, we spend 75 to 80% of the time in non-REM sleep and only 20% of the time in REM sleep. Now out of non-REM sleep, the first, second and the third stage, mainly the stage 2 comprises 55% of the sleep part, NREM sleep. In stage 1, the body starts falling to relax and you start sleeping. Stage 2, the brain slows down, stable light sleep is there. You know what's happening around you. Somebody is opening a door, somebody is opening the cupboard, somebody has come, some bell is there. You are in stage 2. For stage 3 and 4, the body tissue restoration takes place. It's called as a deep restorative sleep. And the last is REM sleep. It's the learning and the memory consolidation takes place. We call it a dreaming sleep. Now we diagnose these things, or we observe this sleep pattern through EEG, electrooculography from the eyes, and electromyography, EMGs. They help in collecting different waves from different parts of the brain, like alpha, beta, theta, gamma, and delta waves, leading to differentiation in the different stages of the sleep. Slow wave sleep considered as most restorative sleep, occurs in first half of the sleep, and 20% of sleep time is spent in this stage. This is important for few other diseases which I will be touching later. And there's increased vagal tone, there's a decreased sympathetic activity which lead to decrease in the heart rate. It's like bradycardia is there. The decrease in the blood pressure and the cardiac workload also gets decreased. Now I'm showing here a sleep cycles. One cycle, sleep cycle is try to understand, one sleep cycle comprises of one NREM and one REM sleep. Now this full cycle, one REM and one NREM is around for 90 minutes, 1.5 hours. And we have 4 to 5 such cycles in a single night. You can see the initial part of the night, there's more of NREM, the dips are more. And as the night progresses, you have more of the REM sleep is there. So in the initial part of the night, there is a slow wave preponderance, and in the later part of the night, the REM sleep preponderance is there. You have more of the REM parts. Again, I'm trying to show something on the hypnogram. The initial part of the night, you can see the red circles. Slow wave preponderance is there, which are circled red, and the green circles being showing the REM sleep, and which is there in the later part of the night, which is circled green, or the blue bars. Again, polysomnographies are there. That's the graph which you get for 8 to 10 hours of the sleep, or maybe any number of sleep the patient is sleep over here, right from 7 hours onwards. So you have the waves coming from the eyes, from the brain, from the chin, and from other parts of the body. We calculate the SpO2, we calculate the pulse, we calculate the heart rate, and the continuous monitoring, video monitoring is there. In stage 1, you can see the slowing of the activity in the upper layers. In stage 2, you have the K complexes. I don't know if I can show you here. I think pointer is not working properly. Anyway, pointer can you need pointer चला. Anyway, in stage 2, you have K complexes, and for the REM sleep, this is the pattern which we observe. Certain physiological changes which take place in the awake state, in the REM sleep, and the NREM sleep. You have the maximum parasympathetic activity going on in the REM sleep as compared to the wakeful. And sympathetic activity is there in the wakefulness, less in NREM, or it's decreasing in the REM sleep. Same way is the heart rate, the blood pressure, and the cardiac output, which stay normal in the wakefulness but decrease to some extent as there's an NREM sleep or the REM sleep is there. Now how this wake control mechanism works? There's an accessory pathway in the form of reticular formation, goes to the thalamus and the cortex. Certain neurotransmitters are involved, like norepinephrine from locus coeruleus, 5-hydroxytryptamine, dopamine, and some cholinergic pathways they play in. Orexin or hypocretin is a neuropeptide which is secreted by the hypothalamus. It's a very important hormone. It regulates the arousal, wakefulness, and the appetite. And if there is a lack of orexin, you have obesities and narcolepsies. I've tried to show basically the typical part, the flow in non-REM sleep. It originates at ventrolateral preoptic area, suppresses the activity of the wake-promoting substances, and thereby initiates NREM sleep. And for REM sleep, it originates in the lateral and posterior pontine neurons, cholinergic in nature, and exert inhibitory neurons to spinal motor neurons to produce REM atonia. A flip-flop model showing a sleep-wake cycle. There is hypocretin or orexin. There is increase in the norepinephrine, histamine, and serotonin, and you have a depressing effect on the adenosine GABA ghrelin and melatonin. So that's the reason why you remain awake. If the balance is shifted towards a greater activity, wake promoting systems set in and the person gets up. Now, in the lower graph, you see, if the balance is shifted towards a greater activity, on the left hand side, there's more of melatonin, ghrelin, and the sleep takes place, and less on the histamine and serotonin. Again, a sleep-wake switch is like a switch. If there's on one side the acetylcholine, histamine, 5-tryptamine, orexin, and norepinephrine, and on the other side ventral-lateral content, VLPO, and the sleep sets in. So it's a switch, it's a balance. If on one side you have the hormones, other side there's a depressing effect. Decreased REM is associated with synucleins. Now what are these synucleins? They are proteins associated with synapse in the brain, often seen in Parkinson's patients with Lewy bodies. Just a rough idea. Sleep durations for infants it could be 15 hours, for toddlers it could be up to 12 hours, for teenagers up to 9 hours, for adults up to 8 hours, for elderly maybe 6 hours or even less to some extent. Normal sleep is dependent upon the quality, quantity and timing. There is an international classification for the sleep disorders in 2014 which we are accepting now, ICSD-3. Is based on pathophysiology and the symptoms. We classify the sleep disorders basically into 7 criteria. Insomnia, you don't have the sleep. Sleep-related breathing disorders like obstructive sleep apneas. Hypersomnias, more of sleep. Circadian rhythm sleep disorders. Parasomnias. Sleep-related moving disorders like restless leg syndromes and isolated symptoms. I'll be touching briefly all these. Now the first is insomnia. As the word says, there is absolutely a lack of sleep. What will it lead to? It will lead to exhaustion, drowsiness, anxiety, depression, and certain cardiac and metabolic problems. Insomnia could be because of your stress, could be because of the medications, could be because of travel, some heavy meal you have taken the dinner part, excess of nicotine, and poor sleeping habits. You are on the phone, you are with the laptop, and you are awake till 2 or 3 in the morning. And what are the features? Despite the opportunity to have a time to sleep, that's a diagnosis, that's a definition. Despite the opportunity to have the time to sleep with good congenial environment, the sleep is not there. Most common disorders seen in the population, around 10% of the population, inability to initiate sleep is there. Getting up early with poor maintenance of sleep. It is associated with day headaches, body aches, mood changes like irritability, anger, inability to concentrate, and marked forgetfulness. Insomnia is of 2 types, acute and chronic, or short-term or chronic. Chronic is more than 3 months and more than 3 times a week. If you have the clinical part, you label the patient or the person as chronic, and short term is less than 3 months. What's the treatment like? You follow a heart healthy lifestyle, make bedroom sleep friendly place, avoid caffeines and nicotine and alcohol in the evenings, avoid afternoon long naps, go to sleep and wake up around the same time. A regular physical activity or even a yoga will definitely help you. Eat meals on regular schedules, don't have late night meals, and meditation does play a big role for insomnia. Certain medications which we are using classified into following, which I have mentioned over here. The benzodiazepines, certain benzodiazepine receptor agonists, melatonin receptor agonists, orexin receptor agonists, and tricyclic antidepressants. Normally we are using zolpidem, the benzodiazepine receptor agonist, which is pretty safe, or remeltron, which is the melatonin receptor agonist, which is a pretty safe drugs. Now the second is the sleep-related breathing disorders. Now what happens during sleep? The gravity and the muscle relaxation allows the tongue and the surrounding soft tissue to fall back into the throat, obstructing the airflow. The sleep-related breathing disorders are basically obstructive sleep apnea, which you see in adults or pediatric, Central sleep apnea syndrome, there is an absolute absence of airflow and the effort also by the breathing muscles. Sleep-related hypoventilation disorders and sleep-related hypoxemia disorders, in which there is marked low oxygen saturation is there with raised carbon dioxide concentration. I will be touching only the obstructive sleep apnea, which is the most common. I have mentioned, tried to show over there that obstructive sleep apnea could be a mixed one, could be a central one, or could be a generalized. In the central apnea, the most important thing which you observe in the polysomnograph, that there is no airflow and the effort is also missing. On the top one, obstructive, is basically the tongue or the soft tissue has fallen back on the airflows. Effort is there, but the flow is not good. What are the criteria of obstructive sleep apnea? You see, there's a large or obese patients with large size necks, complain of sleepiness during daytime, non-restorative sleep, fatigue or insomnia symptoms. Patient wakes with breath holding and gasping and choking. Basically, the bed partner reports the habitual loud snoring which is associated in these patients, and interruptions in the breathing or even both. Snoring and interruptions could be both. Patient is often diagnosed with hypertension, cognitive dysfunction, mood disorders, or even coronaries, CVAs, congestive heart failures, diabetes, or atrial fibrillation. Now, treatment lies with lifestyle changes and certain therapies. First, we follow the lifestyle changes like loss of weight, regular exercise, quit smoking, quit alcohol, nasal decongestants, avoid anti-anxiety or sleeping pills. For therapies, you prefer non-invasive therapies over the invasive ones, like cognitive behavioral therapy and biofeedback. That's the latest which is there in the world market. CPAPs we are using, oral devices we are giving, full face mask is advised in certain situations, and if nothing comes up, surgery is advised. Third is hypersomnias. Now, hypersomnia means that there is an excessive of sleep. Its ability to regulate sleep-wake cycle that gets impaired. Hypersomnia is of the following types, but basically I will be discussing the narcolepsy one. Narcolepsy type 1, narcolepsy type 2, idiopathic hypersomnia, Kleene-Levin syndrome, very important. Hypersomnia due to medical or psychiatric disorders. Hypersomnia due to medication or substance abuse because of lack of wake promoting substances and insufficient sleep syndrome. Now, what is narcolepsy? It's a daytime sleepiness. There's catalepsy, hypnagogic hallucinations are there. Now, what is this? That one is falling. There's a false perception of sight, sound, smell, touch and taste, and there's a sleep paralysis. Catalepsy, there's a loss of muscle tone. The treatment is gamma hydroxybutyrate or GHB. This is also known as date rape drug, and salt is sodium oxidate. Person taking this drug when mixed with alcohol goes to sleep quickly. It's a banned drug now. Mechanism of action works through GABA B mechanism, whereas the benzodiazepines work through GABA A. Modafinil can also be given as it keeps the person awake, and narcolepsy is often associated with hypocretin system, and orexin is deficient. Fourth is circadian rhythm sleep disorders or delayed sleep-wake disorders. In the circadian rhythm sleep disorders, you have delayed sleep-wake phase disorder. The person sleeps around 4 a.m., but the duration maintains that he sleeps for 7 to 8 hours. He doesn't get up around 6 or 7 or 8. He sleeps for 7 to 8 hours. Now, advanced sleep-wake disorder seen in elderly patients. They sleep early, get up early. There is irregular sleep-wake rhythm disorder, non-24-hour sleep-wake rhythm disorder, seen in shift worker disorders and jet lag disorders. Chronotherapy is being used or promoted. It aims to restore proper circadian rhythm pattern of sleep-wake cycle through adequate hygiene, timed light exposure, and use of chronobiotic medications like melatonin. Fifth is parasomnias. It's an abnormal behavior during sleep. You can have sleepwalking, sleep talking, striking or hitting people, or even nightmares. It is NREM related parasomnias. You can have NREM related parasomnias and REM related parasomnias. Now try to show over here that NREM related parasomnias, they include confusion, arousedness, sleepwalking, night terrors, and sleep related sexual behavior. In REM related, it includes REM sleep behavior disorders, recurrent isolated sleep paralysis, or nightmare disorder. Sixth is sleep-related movement disorders. Restless leg syndrome, which is very important, very common. Periodic limb movement disorder. Sleep-related leg cramps, bruxisms. Benign sleep myoclonus of infancy. Propiospinal myoclonus at sleep onset. And sleep-related movement disorder at sleep onset. Out of all, I'll be touching the restless leg syndrome, which you have so many clinical patients. It is defined as an urge to move legs accompanied by or thought caused by uncomfortable and unpleasant sensation in the legs. They begin or worsen during the periods of rest, such as lying down or sitting, often relieved by walking or stretching the limbs, or as long as the physical activity continues, and occurs exclusively in the evenings or the night. You don't have these in the daytime. And the important part, if you have a case of restless leg syndrome, must check in your serum iron levels, because often these levels are low, and you just treat this iron part in the patient, and the patient is cured. Certain drugs are advised, like gabapentin, pregabalin, propranolol, pramipexole. That's what clinical will be used. Certain sleep facts. The longest someone has gone without sleep is 11 days and 25 minutes. A brief word about Kumbhkarna. We all read in the mythology that a man who used to sleep for 300 days, or maybe close to 2/3 of a year, brother of Ravan, a devotee of Lord Brahma. It was basically the Devas, they requested Goddess Saraswati to help them because he was about to kill them. But clinically he suffered from hypothalamic syndrome, the Kleene-Levin syndrome. There is a bilateral ventromedial nucleus involvement and characterized by periodic episodes of somnolence, hyperphagia, along with behavioral cognitive difficulties. Different species sleep in different postures while sleeping, and different areas of the brains are activated. Like dolphins, they sleep in the upright position, and one hemisphere of the brain is active, other is sleep. Horses and giraffes sleep less than 3 hours, whereas armadillo and opossums, they sleep for more than 18 hours. Elephant sleeps much less than other animals. Tigers and elephants have almost the same amounts of sleep. The key factor to sleep is 10 minutes. If you can sleep in 10 minutes when you are lying on a bed, that's a golden rule. Otherwise, you must take some efforts, some exercise, take care of your diet part. Few entities have come up. What is somnophobia? It's a fear of falling asleep. Orinophobia is a fear of nightmares and dreams. Clinomania is irresistible urge to stay cozy in the bed. And dysania is feeling when woken, don't want to get out of the bed. Few words about sleep hygiene. Bright screens like TV, video games, phones and laptops affect the circadian rhythm, should not be used late in the evening. Avoid alcohol for at least 4 to 6 hours before going to bed. Avoid caffeine and nicotine usage in the evening. Avoid strenuous exercise also before going to the bed. Thank you so much. I'll entertain any questions. Gentlemen, the best drug? Yes. Drug is not there. There are other non-medical medications techniques should be used, like regular exercise, diet control, breathing exercises. long walks, they should be encouraged before starting a drug. Melatonin, which we are using, no doubt, but before starting these, a lifestyle modification, if advised, you can cure the patient to 90% of it. Otherwise, all sleep-inducing drugs, they are habituating ones. Once put on, it will be difficult to take them off. Diazepam, that's a panic disorder. For panic disorder, we are using. That's an indirect effect for the sleep, not a good drug for sleep. If the person or the patient comes to you with panics and all, only then the clonazepam we indicate, but not directly for the sleep part, no. Basically, we go in for benzodiazepines. But even those, now the latest is that don't start medication immediately.
Thank you, Dr. Arun, for an enlightening talk. So next I invite Dr. Sonu Sharma. He's DM Cardiology at Delhi Heart Institute and Multi-Specialty Hospital. He will be